Welcome to today's ICU case discussion. A 58-year-old male presents with high-grade fever, confusion, and low blood pressure. On arrival, his blood pressure is 82 over 50 millimeters of mercury, heart rate 125 per minute, and temperature 39.5 degrees Celsius. The patient appears drowsy, restless, and poorly responsive to verbal commands. At this stage, what diagnosis comes to your mind? Think carefully before we proceed. This patient fulfills the criteria for septic shock, a life-threatening medical emergency. Sepsis is defined as life-threatening organ dysfunction caused by a dysregulated response to infection. Common sources include pneumonia, urinary tract infections, abdominal infections, and bloodstream infections. To identify sepsis early, clinicians often use the Q-SOFA score. Altered mentation, respiratory rate above 22, and systolic blood pressure below 100 are key parameters. A score of 2 or more suggests a high risk of poor outcomes. Now let's discuss the investigations that should be ordered immediately. Send complete blood count, renal function tests, liver function tests, and serum lactate. Obtain blood cultures before antibiotics whenever possible. Elevated lactate levels indicate tissue hypoperfusion and severe disease. The cornerstone of early management is aggressive fluid resuscitation. Current guidelines recommend 30 milliliters per kilogram of crystalloid fluid. After fluid administration, reassess blood pressure, urine output, and perfusion. If hypotension persists, vasopressor support becomes necessary. Norepinephrine is the first-line vasopressor in septic shock. The target mean arterial pressure is usually 65 millimeters of mercury or higher. Early antibiotic administration saves lives in septic shock. Broad-spectrum antibiotics should ideally be administered within the first hour. Once culture results are available, antibiotics should be tailored appropriately. Let's review some common mistakes clinicians make. Delaying antibiotics significantly increases mortality. Failing to obtain cultures and inadequate fluid resuscitation are also frequent errors. Another mistake is relying only on blood pressure without assessing tissue perfusion. Clinical pearl: treat septic shock early, aggressively, and systematically. Question: what is the recommended first-line vasopressor in septic shock management? The answer is norepinephrine. Follow Medical Global Academy for more clinical insights and real ICU case discussions.